All right, everybody, let's go ahead and talk about Chapter 6 already. Communication Assessment and Intervention, Evidence-Based Practices. With this chapter, we're going to talk about what is evidence-based practice, what is assessment and intervention, and what are some common approaches and really some overall approaches to intervention for communication disorders. Speech-language pathologists and audiologists have a ton of roles and responsibilities. We are advocates for people with communication disorders. We often hold people's important information and data. And we're administrators for a lot of things. But the most important things that we do are really assessment and diagnosis and intervention and treatment. So first thing we have to talk about is evidence-based practice. And you've probably heard this before, and if not, you're going to hear it a million times after this. Evidence-based practice is the integration of current scientific evidence. So the latest research, good research, understanding what good research versus not so great research is, clinical expertise. So once you're a clinician, understanding clients you've had before, talking with other clinicians about their experience with children who present like the one you've got on caseload, and then also the client perspective. So what are the needs, wants, and hopes and goals of the clients and what's important to them? And the idea is that if we integrate all three of those, are always thinking about and doing our very best in all three of those areas, that's going to equal the best possible outcome for the client. So if we're thinking about the client and what the client needs and wants, if we're focused on our own expertise and the expertise of others, and if we're up to date on the best way to treat and work with clients like these, if we do all of that, we're going to give them the best possible treatment. So this is just, there are lots of different ways, lots of different diagrams, but again, evidence-based practice is the integration of best research evidence, clinical expertise, and patient values. All right, so as we go then, we're going to talk mostly about assessment and a little bit about treatment. So always thinking about those three things as we go forward. All right. Assessment is the systematic process of gathering information about an individual's background, their history, their skills, their knowledge, perceptions, feelings, and probably some other things. It can involve many people and disciplines with diverse knowledge, skills, and experiences. Right? It can be a school-age child, it can be their parents, it can be classroom teachers, special education teachers, it could be an audiologist, it could be a doctor, a nurse, the school psychologist, the social worker, right? We can get lots of people involved. If we're in a hospital, again, we've got doctors, nurses, dietitians, social workers, lots of people involved. And that, we can't think about an assessment as a test. A test can be a part of an assessment, but sometimes it's the least important part of an assessment. So the purposes of an assessment are to identify skills the person has and those the person does not have in a particular area of communication or swallowing in our field. And it's always important to remember that we're not just looking at what someone can't do really well. We're also focused on what a person can do really well, because not only do we have to work with the whole person, but also identifying what they can do well might help us in improving what they're struggling with. We want to assessment's also going to guide the design of intervention for enhancing a person's skills in a particular area of communication. All right, so once we do our assessment and start to think about what the problem is and that helps us then figure out how we're going to work on that problem. And it's also, we're going to monitor a person's communicative growth and performances over time. So assessment doesn't just happen at the beginning. We'll do sort of a big assessment at the beginning, but we're always assessing, reassessing. Are we making progress? Is this what the client wants and needs? Is this the best possible approach, right? And then it's also, right, to qualify a person for special services. So if we're in the schools, to get them on the IEP or some type of plan that they can receive services if they need them. And then in a hospital, for insurance or something else that will qualify them to receive services that they need. So we'll talk about the process, and so we've got screening and referral, and then we'll go on down the line and we'll talk about each one of these. Okay. So screening is the delivery of a test or task that provides a quick check of an individual's performance in a particular area. It identifies those who require a more comprehensive assessment. So screening can be, screening is not assessment. Screening may lead to an assessment. So screening is most often done with young children, so that, in most states, when right after a child is born, they'll get their hearing screened right in the hospital within 48 hours after birth to see are the ears picking up the electrical signals that are needed to be able to hear. So, obviously a one-day-old child's not able to tell us whether they can hear or not, but we can see, is the ear reacting to sounds the way a person who can hear would react to sounds. There are two types of screenings. The first is a developmental screening, so that's an example of a developmental screening. And then also, maybe every kindergartner, gets their hearing checked and then maybe goes through a quick speech and language screening where the child makes some sounds, looks at pictures, says some words, just to see, all right, is there anything we can catch really quickly? And then there's also an injury-related screening. So if someone gets a traumatic brain injury in the hospital, right, there'll be either a nurse or a speech language pathologist, right, will look at the person's eye movement, ask them some questions about memory, things like that, to do a quick screening to see if, again, a full assessment is then needed. Referral will often accompany a screening and describes the process by which the involvement of speech, language, and hearing professional is formally requested. So typically a nurse or doctor will refer a patient, but it could also be a classroom teacher. It could be a parent, could self-refer. Once a referral is made, the SLP will determine whether a more comprehensive assessment is warranted. So you might do a quick screen with somebody and then say, okay, we need to do an assessment. All right, so there are lots of parts. Again, an assessment's not just a test. We've got chart review, interviews, systematic observation, questionnaires, surveys, some more informal testing. We've also got formal testing, and there's usually instrumentation of some sort involved. All right, so we're going to make a diagnosis, right? So does the person have a speech language disorder? And then for the differential diagnosis, right, if they have let's say they have a language disorder, right, what type of language disorder do they have for the differential diagnosis? Is it expressive language, where they have a hard time expressing and using language? Is it receptive language where they have a hard time understanding the language of others? Is it both? Right, so making a more true diagnosis, and we're going to determine the severity of the disorder, usually ranging from very mild to very severe. And then also characterizing the patient's prognosis. So does the client have a really good chance of improving and or recovering? Is there minimal chance of that happening, right? So if we have a person in their 80s who has dementia, right, there might not be great prognosis, right? Maybe we can keep them where they are a little while longer, but part of dementia is that it's going to get more and more severe as we go, no matter what we do about it. All right, developing an intervention plan. We're going to identify treatment goals. Right, so once we have that, so if we back up, right, once we have the assessment findings and we have the diagnosis, the differential diagnosis, then we're going to come up with a plan. We might identify treatment goals. We're going to start to describe the possible length and frequency of treatment. Maybe describe treatment context. So, is it going to be in a therapy room? Is it going to be done at home with the parents? Different activities that could be done. And if we're making goals, and if I'm the person who's going to be doing the intervention, I might make those goals right at the assessment. If someone else is going to be treating somebody, I'm generally not going to write out goals because that person treating them may have different ideas and different way of treating, so I'll be a little bit more vague. But if I'm writing goals, either if I'm the therapist or I'm going to be the therapist, you've got to remember that goals have to be functional, right? So it can't just be that, our client is able to look at a picture of a hammer and say the word hammer. Well, that's super, but are they able to speak in sentences? Are they able to remember things they need to remember? Like, is it functionally important for the person's life? Is it measurable? So I've got to know, right, is there a way to measure whether or not the person achieved that goal? And is it attainable, right? Are we reaching way too high for somebody, and maybe we need to gear back, at least at first, on what our goal is here. All right, and again, like we said, assessment's not a one-shot deal, right? Assessment's an ongoing process that monitors progress and outcomes for the client. So as we're going in therapy, we're always monitoring, always problem solving to see how we're doing. Assessments used to monitor a client's progress during treatment, to modify the treatment plan as progress is made, and to determine when a client should be discharged from treatment, right? Have we reached our goal? Are we going to reach our goal? Is the client interested in more therapy, right? Constantly assessing. SLPs and audiologists use a variety of instruments to identify an individual's strengths and needs in communication and to develop an assessment protocol that's sensitive, comprehensive, and non-biased. I mean, it says non-biased, right, in the book, but right, everything has bias, but we want to keep things as unbiased as we possibly can. And in order to do that, usually we've got to do a lot of different things, right? You can't give one test and all tests are inherently biased, right? So we've got to do a lot of different ways to assess people to get the full picture. Right? Different types of assessment instruments. We've got norm-referenced instruments. We've got criterion-referenced assessments, performance-based assessments, and dynamic assessments. All right, norm-referenced instruments. They're going to be standardized, And that's where the test must be given in a uniform and scripted manner so that it's given in exactly the same way to everyone who takes it, because we're going to compare how you do on the test to everybody who's taken the test. So we have to give it the same way to everybody, or else you can't compare, right? So if you took the SAT or the ACT to get into college, right, it's a standardized test and your score was compared to other scores. So it has to be given in the same time constraints, in the same kinds of settings, and the same way to make sure we can compare across people. All right, the normative sample is the group of individuals who are given the test to identify standards of performance at specific age levels, right? So again, in the SAT, it was all of your peers who also took that test, right? If we have a preschool language test, right? It might be all 3-year-old boys that we're going to compare to our 3-year-old boy, or all 3.5-year-old girls that we're going to compare to our 3.5-year-old girl. And the standard scores are the index that identifies how a person's test performance compares to that of their normative peers. We'll talk a little bit more about that here coming up. So we end up with a standard normal distribution, and that's derived from mathematical models of probability regarding how scores will range from a skill or aptitude that's assumed to be normally distributed within the population. And we'll look at a standard normal distribution in a second. Just some terms. So raw score will be the total number of errors or number correct on an assessment. So when you took the SAT, right, maybe you got like 74 questions right. All right, well, that's your raw score, but that's not your standard score, right? That's not the score that you end up with. So the standard score is the individual score that compares them to peers. So if we stretch out all the raw scores, was your score above average, below average, and then we're going to put a standard score on that shows where you fell in line with above average, average, below average. Right? The mean is the average score. The standard deviation is the variability from that score. And the percentile rank is what percentage of scores were below a given point. So if you have a like 68th percentile rank on the SAT, that means that you scored higher than 68% of the people that took that test, right? That's percentile rank. So again, you take a test, you have a raw score, and then, right, that's the sort of picture, that's the standard normal distribution of everybody who took that test, right? Most of the scores are going to be in the middle, and then the really low scores, there aren't many of them. The really high scores, there aren't many of them. So it slopes up and down, and then depending on your raw score, we're going to plot you on that graph and then come up with your standard score based on where you scored in comparison to everyone else who took that test. All right, so it can be really helpful to know, right, again, in comparison with everybody else, your age and maybe your gender and whatever else we're comparing you to, how did you do compared to all those people? We've also got Criterion-Referenced Assessments. And they determine an individual's level of achievement or skill in a particular area of communication, right? So we're going to require an establishment of a clear standard of performance, so that if we have kindergartners and they come in September, maybe we give them, and the goal is we want to see, how many letters can they correctly identify in 1 minute, and that the goal maybe is that before Christmas they can identify all 26 letters in less than 1 minute, right? That's going to be the standard of performance that we're looking for. All right, so that's criteria. You've got a certain criteria, right, that before December 15th, or whenever Christmas break is, children are going to have, let's say, be 95% correct in identifying letters, right? That's the criteria we're going to establish for them to pass or not pass. We've also got performance-based assessments, sometimes called authentic assessments, and they describe an individual's skill or behaviors within authentic contexts of use, such as at home, at work, in the classroom, in the community. And the rationale behind that is that how we communicate and our skills in communicating are really influenced by context, influenced by who we're talking to, how we're being talked to, the environment, and that traditional models of assessment are often of limited use in planning treatments, and that traditional models of assessment might work well with maybe more traditional students, but more, if we have students that might be more untraditional, we might want to do, they might not have a lot of value, right? So we might want to be careful in how much we care about a standardized test score, right? I had a good friend that for a while worked out in Arizona, worked with Native American children, in schools out there, and a lot of times standardized tests, you would use them, but they weren't really normed on Native American kids in Arizona. So they were of use, but we also wanted to see what are these kids, she wanted to see what are my kids able to do right now in school, at home, right? What's their speech like? What's their language like? Right? Are they able to do what they need to do? So you would use lots of artifacts, right? Homework assignments, maybe a letter that they wrote, maybe a story retelling, something like that. And then you might collect all those artifacts into a big portfolio, and analyze them all together over time and see, is this child where he or she needs to be, and are they making progress? All right. Sort of an example of a performance-based assessment, but a little bit different, is a dynamic assessment. And this analyzes how much and what types of support or assistance are needed to bring an individual's communicative performance to a higher level. So this comes from Vygotsky, and we'll talk about Vygotsky more in a minute. All right, so what's the person able to do now, and what is the person able to do if they're given assistance or support, right? So how much learning is that person able to do? How much growth might they have when they're talking, when they're writing, right? So you might have kids who, right, are not able to make any K's, any G's, right? These are sounds that are produced in the back of our mouths, the k, k and the g, g, g sounds, right? Maybe in their speech, they're fronting and all the k sound like a T, and all the g, g sounds sound like a d, 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 because they're fronting. And so you might want to see, all right, just in play, can we kind of play around? Can we get kids to make sounds in the back of their mouth? Just kids that can make those sounds on their own are probably going to be able to do it in connected speech a lot faster than kids that are not able to get their tongues back, not able to make those sounds. So that's an example of a dynamic assessment, not only looking at how they're performing, but given support and maybe changing the criteria around, right, what are they able to actually do, giving maximum support. And we'll talk more about that later. We've also got progress monitoring assessment. So this analyzes an individual's progress during a course of intervention and is used to compare actual rates of growth to expected rates of growth and adjust intervention techniques accordingly. So we're going to be looking at individual growth and development indicators. And this is what we do, or this is what they do in the schools, is response to intervention. So, we'll figure out how a person's doing, come up with a way to measure this. We'll give intervention maybe each morning or either with the classroom teacher. And then we'll do weekly or bi-weekly assessments used to assess progress. So it's like really ongoing assessments with like in-class treatment going on. So not with special education, not with the SLP, just the teacher is going to give a little extra help or a little extra assignments to see if we can bring people up to a certain criteria. All right. Intervention refers to the implementation of a plan of action to improve one or more action of an individual's communicative abilities, if we're talking about our field. And we want intervention to be effective, so we want it to work. We want it to be efficient, right? We want it to work, but it can't be that 9 years from now it's going to work. Is it going to be efficient? How can we get results in the least amount of time and using the least amount of resources? And then is it feasible? So is it realistic? Is what we're doing realistic? Is it truly going to be able to be carried out? Intervention purposes, we've got prevention, remediation, and then compensatory strategies, right? So if you have children in a really low income area, and we know that socioeconomic status is going to be a big predictor for reading ability and early school ability, right? So maybe you start a reading group for preschoolers in a low SES, a low economic area, and try to prevent as many children as possible from struggling in school with reading and language. Remediation, so a child has already started to have a language disorder, and then working to actually get that child up to speed and actually put them in sort of the average range of language so that they no longer need therapy, that they can perform well in the regular classroom. And we've got compensatory strategies, right, and purposes. So if you have a child who has dyslexia, right, they're always going to have dyslexia, right, but what can we do to help them compensate and perform well, even though, they're still going to have a different way of reading, a different way of understanding text, but can we help them compensate for that difference, right? So our goals is really the targeted communication achievement of an individual. So exactly, what are they going to achieve in how much time? The procedure will be how are you going to do it? So the clinician's plan of action. And again, characteristics of good goals, it's going to be functional and meaningful for that person. It's going to be measurable. We'll be able to know whether they've achieved it or not. And it's going to be attainable, that it's not some impossible goal that will never actually happen. We're going to have some different phases. We're going to have long-term goals for that, if you achieve this, then you won't need therapy anymore. You'll also have more short-term goals, so maybe what you're going to achieve over the semester, let's say, or over a month or two. And then you're going to have session-level goals. So what are we going to do this session or this week, and what goal are we going to try to achieve that will take us to our ultimate goal? In the schools, we've got some different models. Sort of the traditional model was the pull-out direct service model, where the speech-language pathologist would go into the classroom, would then pull out one child or a group of children and provide therapy in the speech-language classroom. A lot more people are moving to a co-teaching or parallel instruction model, where the speech-language pathologist actually goes into the classroom and works on teaching language to the whole class, but also focusing on the speech and language of the people on her, maybe she's got 3 people on her caseload in that classroom, right? Be teaching to the whole class, but focusing on goals for those 3 kids. And then there's also intervention consultation. So, right, can we give the teacher ideas for things to do, the parents ideas for things to do, so that they're not actually in therapy, they're not being pulled out for class, the SLP is not going into the classroom, but the SLP is working with the teacher, the special education teacher, the parents, so that they can provide intervention on their own. And then we've got 4 sort of major intervention approaches that your book talks about. Often we're going to mix these approaches, but here are 4 of the main intervention approaches. The behaviorist approach is based on classic learning theory, which emphasizes the importance of the environment for shaping behavior, and in particular, the influence of consequences on behavioral change. Clinicians are responsible for identifying observable and measurable goals, specifying the level of mastery at each goal, controlling each intervention session, and collecting data in each session. So behaviorist therapy is going to be really sort of clinician-led. We're going to have specific goals. You're going to work up a hierarchy, take a lot of data, and a lot of drill to try to reach our goals. And we've also got linguistic cognitive approaches. These are based on theories of developmental psychology and cognitive science, which emphasize the developmental sequences and underlying rule-governed organization of communicative behavior. Okay. We're going to be talking a lot about the goals of communication acquisition, the when, the how, and the why. So, why does this person want to speak? How can they speak best? When do they speak the most? Helping them, that should be learn the rules that underlie successful communication, right? So maybe we've got to take turns, maybe, making all the sounds of the English language if we're, working in English, and, rules about language, and the learner's fully engaged in the intervention process. So it's not just drill, right? We might be playing some games, we might be working on goals as we're playing games and learning about speech and language. We also have social interactionist approaches, which are based on theories of developmental psychology that emphasize the importance of social interactions among individuals as a critical means for development and learning. And this takes us back to Vygotsky and what Vygotsky did and wrote about and learned. And so just some terms here. The social plane, so Vygotsky believed that all learning, or at least almost all learning, first took place socially. So especially if we're talking about language, right? The child's home, young child's home with the parents. The parents are using words sort of in the social space, the social plane. The child then starts to understand what they mean. Once the child knows what they mean and knows how to use them, they have entered their psychological plane. So that's the knowledge that the child possesses internally and independently. So Vygotsky believed that knowledge started out socially, that other people knew things and talked about things, and then the child learned things and they become part of their psychological plane. The zone of proximal development is the range between what the child or the individual can actually do on their own, and it begins there, and the zone ends where sort of at the maximum level, the maximum thing the child or person is able to do with maximum assistance. So, if I give somebody lots and lots of help, right, are they able to do a certain skill? Right, so for me, I might be working with a 12-year-old who, has a lot of stuttering in their speech, when they're talking, when they're reading, right? If I'm there with them, giving them a lot of help, right, they might be able to be pretty fluent, but that's with a lot of modeling, a lot of working with the environment just perfect, right? So their zone is in between, what they're able to do by themselves and what they're able to do with maximum assistance. And then the idea of scaffolding is that assistance. So the scaffolding is the assistance provided by the person to help them reach their maximum level of ability. And the goal is, really as therapists, we want to kind of scaffold using hierarchies so that we can kind of start where the client is, move up one step harder, get them there, and then move up one more step harder and keep going, right, until they're able to do everything that they can do with us on their own, right? So, and Vygotsky there's some issues with the work of Vygotsky, but I think these are some really important concepts overall that we need to know. Lastly, we've got family-centered intervention. So in family systems theory, the family as a whole is greater than the sum of its parts, right? So the treatment goals need to emphasize the individual's participation within and access to family activities and contexts, and it's got to incorporate family members' perspectives regarding viable treatment approaches, right? So the idea that the child's not just the child, right? We've got to understand the child, we've got to understand the parents, what the parents want, what the child wants, and that the child's not just all by herself, that there's also family interaction going on, and that treatment goals, and this is part of evidence-based practice, so no matter what kind of therapy or intervention we're doing with a child, right, it has to be family-centered because we have to be thinking about the goals, the wants, and the needs of the family. So there we go, Chapter 6.